Welcome to today's session entitled Complex Care, Funding Big Problems on a Small Budget. Before we get started, I'd like to go over a few items so you know how to participate in today's event. When you joined today's webinar, you selected to join either by phone call or computer audio. If for any reason you would like to change your selection, you could do so by accessing your audio pane in your control panel. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send your questions in at any time. We will collect these and address them during the Q&A session at the end of today's presentation. I would now like to introduce John Feather, CEO of Grant Makers in Aging and moderator for today's webinar. John?
Thank you, Kat. I'm delighted that so many of you have joined us today. Before we get started, I want to thank the supporters of this webinar, the Five Funder Collaborative, which includes the Commonwealth Fund, the John A. Hartford Foundation, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. We thank them for their support of this work, which allows us to provide this free of charge to our audience today. We also want to thank our colleagues at Grant Makers in Health for their collaboration on this project. To improve the health outcomes and daily lives of individuals in the United States with the most complex care needs, these five foundations are working together to accelerate healthcare transformation. As a first step, the collaborative partnered with the Institute for Healthcare Improvement to create a dynamic website called The Playbook, Better Care for People with Complex Needs. Grant Makers in Aging and Grant Makers in Health have joined with the collaborative to promote the playbook and the research behind it among funders and to create a new invitation to innovation initiative. Today's webinar focuses on funding improvement and innovation in complex care on a smaller budget. We are so pleased to be joined by Mark Humowiecki, the Senior Director at the National Center for Complex Health and Social Needs, and speakers from Transforming Care Partners, Loren Pogir, Erich Bagen, and Meredith Lobel. Welcome to you all. As I mentioned earlier, as was mentioned earlier by Kat, you can enter your questions at any time. Please go ahead and do so whenever one occurs to you. I will be reading them to our panelists later in the hour. So Mark, let's start with you. Tell us a little bit about the overview of how to approach complex care funding on a smaller budget.
Thanks, John. I'm thrilled to be with you all today. Next slide. So I like following good order here with the Grant Makers webinar. I want to thank our sponsors at the National Center for Complex Health and Social Needs. These are our founding sponsors, Robert Wood Johnson Foundation, AARP, and the Atlantic Philanthropies. And the Camden Coalition is the organization that the National Center is part of and is an initiative of. Next slide. So this is me, and I am the Senior Director. As I said, the National Center is an initiative of the coalition. The Camden Coalition is a local organization in Camden, New Jersey that's been around for 16 years. It's been focused for most of its history on complex care, even before we had that name, really on innovating new ways of promoting health and wellness for the most vulnerable and expensive people within our healthcare system. Over the last number of years, we have seen, well, next slide, please. The National Center was started in 2016 as a result of a growing realization that there were individuals and organizations around the country who were innovating new ways of promoting health and wellness for the most vulnerable and expensive populations within our system. They were sometimes in large systems, sometimes in small nonprofits, but a common experience was that they did not have access to peers and support in their complex care work. They were often isolated. there was no member organization or annual conference to go to talk about complex care. So the National Center was launched in part to serve as a professional hub for this emerging community of people focused on most vulnerable populations and transforming health and social services and how we meet those needs. We also see complex care as an emerging field, meaning that there are a set of knowledge, there's a set of activities and models that need to be refined and replicated throughout the country. And we see the role of the National Center in partnership with the Five Foundation Collaborative and many others in this field as playing a significant role in organizing and catalyzing the work of this field. Finally, we use the term movement here because we think that doing healthcare and providing health for people with complex needs requires more than just technical solutions. It requires a change in attitudes. It requires change in policy and payment. It really requires aspects of a social movement to reimagine how we provide health in this country, particularly for the most vulnerable. Next slide. So what is complex care? Briefly, we know that within the healthcare system, a small number of people are responsible for a disproportionate amount of costs. Common statistics are 1% account for 22% of costs, 5% of patients account for close to 50% of costs, and that for many of those populations within those 1 or 5%, the root cause of their high cost is not merely a disease, but is a constellation of medical, social, behavioral health needs that together confound the approach of our traditional healthcare system. And so complex care is about reimagining and restructuring how we approach those needs. And here are some principles on the slide that sort of get at the heart of what complex care is. It's person-centered, meaning it's designed around the needs of the person rather than around the needs of the system. It's whole person focused, meaning we don't look just at medical or disease needs, but also behavioral health and social factors. It's interdisciplinary and cross-sector, meaning this work has to be done in teams. It has to be done across traditional barriers and silos of healthcare or social services, government or nonprofits. It's data-driven, not only from using data to identify who the populations are that we want to be working with, but also to evaluate the impact that the work is having on them, and to understand the problems more broadly across these different sectors. There's a lot of research that still needs to be done. It's equitable insofar as it's recognizing that a lot of people with complex needs are that way because of structural inequities, because of health disparities in our society, and that to get to solutions, we're going to need to take on those issues head on. And it's designed in partnership with communities and consumers. Next slide, please. As I mentioned at the outset, the National Center sees itself as helping to catalyze a field, and we're in the midst of a project right now with our partners, IHI, who John mentioned at the top, has produced this playbook for better care, as well as the Center for Healthcare Strategies, which has been a leading voice and player in the complex care movement for the last 10 years. Together, we are taking stock of the community of complex care and the field where we are strong, where there are needs to invest, and we're trying to be very strategic as a community to point to those areas that need the greatest investment. So this is a framework that we are adopting called the Strong Field Framework. It describes sort of basic components of any field of social change: standards of practice, knowledge base, leadership and grassroots support, and funding and supporting policy. Those over the top is a shared identity, which gets at who is this community, what's it trying to achieve, and how is it trying to achieve that. That's where we are right now as a community of complex care. We're early in our coalescence. We've started to really pull together the major institutions as well as the individual thought leaders in this space to come together to reflect on how far we've come and where we need to go. And some of the recommendations that I will discuss as we go on comes out of some of that self-assessment that we've done as a field to really understand where we need to grow and strengthen ourselves to be able to achieve our goals of really transforming how we deliver health to people with the most significant needs. Next slide. So here are 5 critical areas for support. There are so many needs in local communities, and there are many local communities that won't even have heard of complex care, and so may very much just be getting started. My recommendations here are largely focused on communities that are getting started, and you'll see how they connect back to the principles of complex care that I outlined at the top, as well as the domains of the strong field framework that really get at what does it mean to be a field and to do this work effectively. So the 5 areas I'll discuss are data infrastructure and practice, cross-sector collaboration, clinical training and skills, person-centered care and stigma, and lived experience. Next slide. No surprise, data is a critical need for complex care, and it comes at several different levels. We need data in order to understand the problems and the particular problems in our community. We need data to be able to identify the people with whom we want to work. We need data to understand what's working and what's not working. Too often, social service partners don't have access to high quality data, and a lot of our healthcare data gets locked up. And so my recommendations here, and where we've seen success both in small and large projects, are focused on building data capacity and connecting data across sectors. So we've seen a number of cases in New Jersey where just the act of bringing together different data sets, for instance, in Camden, we brought together police encounter data with healthcare data and looked at the individual level and found out of a data set that contained more than 100,000 people, a small number of a little over 200 people who had 10 or more encounters with the healthcare system, 10 or more encounters with the criminal justice system, and then analyzed their specific needs and found, with no surprise, high rates of homelessness, addiction, and mental health. But they became a subpopulation that, in working with the criminal justice system, we could really try to tailor needs. They were having an outsized impact on both systems because the solutions of healthcare and the solutions of criminal justice, neither was meeting their needs, but by working together, we could start to reimagine how to meet their needs, how to start to change that trajectory of frequent encounters on both sides. That's one of many examples. We also see a need for a community to have access to social service information. People need to be able to make referrals or have partnerships with folks providing food and addressing food insecurity, with folks addressing housing issues, with mental health issues. The whole range of services that any community has often is not well curated, not easy to access. Too often somebody has a outdated manual on their desk that they look up. And we've seen a large number of organizations that are developing online sort of systems like 211 or these sort of Yelp for social services that allow you to be able to navigate and identify the services in your community. Many of these groups are open to working with local communities to do some customization. In Camden, we've worked with a group called Aunt Bertha out of Texas and seen a lot of value to customizing, and then going out and training the entire community on this community resource. Next slide. Throughout the presentation, I keep referencing cross-sector collaboration because one of our core principles is that complex care really sits at the intersection of healthcare and other sectors. And so this is not necessarily the way that healthcare is used to acting, but in order to be effective in complex care, we really need to get out of our own four walls, out of our institutional constraints, and become active collaborators with other sectors. And I've got a long list here, and you could add many more. This requires trust building and breaking down barriers. We've seen small projects have outsized impact in just beginning the conversation, opening people's eyes to the fact that the criminal justice system is working on the very same issues that the healthcare system is working on, and yet they're not coordinating and they're not talking. So we've seen projects where folks have a learning collaborative, or they do a site visit to a well-known project. We've gone on site visits around the country to learn from best practice there. And just the mere act of bringing people together who are unlikely bedfellows, the commissioner of police alongside the CEO of the hospital, having them be part of an experience like that and begin to talk can open the doors to cross-sector collaboration that can be very powerful. For more advanced communities where there's already a commitment to working on these populations, we've seen really effective work like this opioid system mapping that I referenced. In Orange County, they brought together county leaders, state government, local government, across criminal justice, healthcare, mental health addiction, the full panoply of folks that need to be involved. And they did a 5-day lean process system mapping and designed a new system for access to opioid treatment in the wake of the current public health crisis that we're all facing. That type of project can be done for, a relatively small amount of money, can have a huge impact if you bring in the right resources. Next slide. So obviously, a major component of complex care has to do with clinical care, and it's often doing work differently than folks have been taught to do traditionally, particularly inside of healthcare. So whether it's engaging people who have the most complex needs and are often the most alienated from the healthcare system, tools like motivational interviewing can be very critical to having a conversation, getting people to think differently about their situation and their relationship to the healthcare system, to overcome historical problems and build trust between a caregiver and a system and the patient. And so small projects that are focused on providing really high quality clinical training in any of these different areas, team-based care, motivational interviewing, the impact of trauma, the treatment of trauma, mental health first aid. There are lots of different clinical programs that are designed for sort of practitioners to upskill them in these areas that are critical for people with complex health and social needs that can have a significant impact. For communities that are trying to develop a dedicated program or model that's focused on people with complex health and social needs, or a particular subsection of those population, getting coaching from an established organization. We at the National Center provide technical assistance and coaching, but there are other organizations around the country that do training and technical assistance in their models or in their areas of expertise. That coaching can be incredibly valuable when someone's launching a new program and having hundreds of questions each day, looking for the advice and experience of someone who's done this before. And again, that sort of grant to provide that coaching can make the difference between a project that really accelerates and succeeds versus one that sort of gets mired down in early problems. This work is incredibly hard, and so access to support and expertise is critical. Next slide, please. Finally, in order to really do complex care well, we need to change our mental models of who we're working with. To understand that people who are homeless and living with addiction have often been through lives of trauma, have incredible strengths. The fact that they're still alive, that they're still managing to operate within our society despite those challenges. If we take a viewpoint of strength-based assessment, of harm reduction, and really of understanding the stories of the people who we're trying to serve, it goes a long way in changing how we approach the work in ways that it can be very transformational. So in terms of projects, we've seen, again, learning in the field, going and visiting programs that run well for vulnerable populations, really talking to the individuals being served. We've seen groups as they come together early to think about developing a project. One of the first activities is to go and talk to some of the most expensive patients, highest utilizers within their health system, and to really understand their stories. It doesn't take a lot of money, but it does take a dedicated approach to really hear those folks out and to start from the premise that this is about the people we're trying to serve and that they have something to teach us. Next slide. And to take that to the sort of next degree, we think not only at the beginning is it important to understand the stories of the people we're serving, but as an ongoing basis, we need to incorporate the voices and the wisdom of people who we're trying to serve, people that have been through these systems or currently navigate these systems. So people with lived experience need to play more significant roles in the design of programs, in the oversight of programs, in the governance of systems like the Medicaid system in a state or a hospital's safety committee or quality committee or the development of community health needs assessment. There are hundreds of different ways that people with lived experience can be part of that. And rather than do that in sort of a token fashion where you find one or two people from the community to serve, we've seen partnering with established groups of advocates or people with lived experience, whether it's in the mental health system or it's within Medicaid, that there are organizations devoted to leadership development and advocacy for people who are consumers of healthcare, and that partnership there can generate a lot of wisdom at the table where decisions are being made and power is wielded. So we've seen community advisory committees, we've seen connections with other agencies, and we've seen, like in Maine, there was a connection between substance use issues and people with histories of substance use and their Medicaid expansion efforts and advocacy efforts, and that by bringing together those advocacy efforts with the people with lived experience, it was able to take it to another level, not only for the results of the campaign, but also the understanding of the issues by the very people who were trying to advocate for the change. So strongly encourage folks to be partnering with people with lived experience. So I will conclude there, and we'll be able to take questions towards the end of the webinar. Thank you.
Well, thank you, Mark, for giving us that great overview of both the complexity and also the opportunities that this kind of activity provides. Next, we're going to hear from three speakers from Transforming Care Partners. But before we go to them, I want to remind you once again that we will be having a question and answer period after the next set of speakers. So please go ahead and type your questions into the question box that you see on your screen, and we will be answering those questions a bit later on. So Loren, Mark gave us a good introduction to this area. Tell us about what you and your colleagues have been doing in this arena. Loren, I think you still may be on mute.
Hi, can you hear me now?
Yes, indeed.
Oh, super. Okay, thanks everybody. Sorry about that. So thank you, John, for the introduction. My colleagues and I are thrilled to have the opportunity to speak to you about the important role that foundations, really of all sizes, can have in scaling and sustaining care innovations to care for people with complex needs. And before we get started, I did want to share a little bit about Transforming Care Partners as well as the team that you'll be hearing from today. So next slide, please. So Transforming Care Partners is a management consulting firm, and we work with foundations, organizations, and leaders specifically to transform the experience of aging and of life care. And what we've learned in our experience is that there are some brilliant leaders, providers, researchers, and even care innovations. And what we're seeing that the field needs is really this wraparound support to help care innovations get to sustainability and get to scale. Next slide, please. So in addition to me, you'll be hearing from my colleagues Meredith, Lobel, and Erich Bagen. And between the three of us, we have experience in finance, strategy, operations, and human-centered research and design in healthcare and philanthropy. And we've worked with organizations such as IDEO, BlackRock, McKinsey, the Gordon and Betty Moore Foundation, the Stepsky Foundation, the City of San Francisco's Zen Hospice Project, and Experience Corps. And we're all deeply passionate about improving the care for people who are aging and also have a serious or complex illness and could be at or nearing end of life. Next slide. So what we want to cover today are really a few main things. So first of all, we want to make the point that you can have impact even without going to scale. And then that's the first really important thing. Assuming that the goal is scale, what we want to cover is that there's a couple things that are really important to consider as you identify criteria for taking organizations. And the first one that I'll share with you is that there's specific criteria that interventions must meet the majority of. And I'm going to focus specifically in healthcare, but these are also generalizable to other fields. And Meredith will then share with you kind of more of the requirements for a business model that all organizations need to get to scale. And we're both going to highlight the ones in particular that we're seeing that organizations sort of forget to focus on. And then lastly, Erich's going to share with you kind of the overall path to scale and also emphasize specifically how foundations can match the investment type and expectations to where organizations are situated on that path. Next slide, please. So we just quickly want to make the point that there are a lot of great organizations out there, and they've been designed specifically to meet the needs of a particular patient population or geography. And staying that size is actually one of the best ways to meet patient needs. So not all organizations actually need to get to scale to have an impact. Having said that, if the goal is scale, and I think you've seen many really fabulous pilots that really do need to get to scale to have more impact, then there's the criteria as foundations you should be really looking at to think about whether or not this is an organization that you'd want to try to help get to the next level. And if you go to the next page, and the one after that, thank you. Next page, Kat, thank you. So what I want to focus on to start is really kind of what those criteria are for innovation to get to scale sustainability. And there's four primary ones. Thanks, Kat. There's four primary ones, and I'll go into a little bit more detail about all four of these. So essentially, they have to visibly solve a significant problem. They need to align with current incentives. They need to make the right thing to do easier. And this might seem obvious, but implementation does need to be feasible, and that's not always the case. Next page. So the first one I just want to touch upon is this idea that an innovation has to visibly solve a significant problem. And I think all of you have done a really wonderful job of documenting that this issue of caring for people with complex needs is really important, and that there are ways to solve it that will result in substantial improvements. The two things I really want to touch upon is this idea of needing to be able to quantify benefits and the fact that benefits need to be easy to see. And as an example, just Erich and I yesterday were meeting with the local healthcare system CEO specifically about scaling a palliative care program. And what he had said is he's seen the benefits from literature, but he actually needs the benefits quantified specifically for his patient population, for him and his payer partner to actually be willing to pick up something for further scale. And that is actually another example of a really great place for foundations, is to help provide that extra support to be able to quantify those benefits. And the other thing I want to touch upon is that the benefit has to be easy to see. And you're seeing an image on the right about hand washing. And I think we all know that despite the wide recognition that infections are caused by failure of hand washing, people still don't do it. And one of the reasons why is that you don't necessarily see that you're causing that harm. So an infection gets picked up and then much later, and you can't necessarily tie it back to a particular healthcare provider. So something to think about is how do you actually make the value of the problem being solved more visible. And if you go to the next slide, I'll give you just one example of how you could do this. And what you're looking at on the right-hand side is actually a dashboard that was created for the ICU. And the goal was to actually make it visible whether or not the clinical team had done everything that was necessary to prevent delirium. So here's an example where you can actually see that what the team is doing is actually helping to prevent a significant problem. Next slide. So the second criteria that we need to look at is that anything we do has to be aligned with current incentives. And I know we talk a lot about financial incentives and regulatory incentives, as well as leadership buy-in. And the one I want to focus on for a little bit here is the importance of clinical team buy-in. And the example you'll see to the right is some of you may have heard that Blue Shield of California just recently launched a payment model that actually pays for home-based palliative care. And here's a great model that we know is very well aligned with financial incentives. We've seen evidence that palliative care does result not just in better quality of life, but as well as lower unnecessary utilization of the healthcare system. There's tremendous regulatory incentives. In California, the state just passed State Bill 1004, which actually requires health plans to pay for palliative care. And there's tremendous leadership buy-in for palliative care. And the challenge they're having right now, which I do feel like they are going to overcome, is really around clinical team buy-in. And what they're not seeing enough of is physicians referring into the program. So this is just an example of how you really need to look at all of the incentives across the team. And again, I do believe that they're going to overcome this, but you need to be thinking about where there's gaps. And this is another example of where foundations could get involved, is not necessarily to scale the entire payment model, but is there something you could be doing to help with clinical buy-in at the local level. If you go to the next slide. So the third thing, which is very much related to clinical team incentives, is how can we make the right thing to do easier? And I think we know in healthcare right now is so complex. And so we really need to be thinking about anything that we scale as much as possible is going to simplify or expedite existing workflow. And it's got to make the provider's job much easier or simpler. And the extreme example that you're seeing on the right-hand side is this is an image of a photograph of the reenactment of the first public demonstration of the use of anesthesia for surgery. And this took place at Mass General. And here's an example of innovation that, could you imagine surgeons, not using anesthesia right now? So this is an extreme example of something that's making it much, much easier for surgeons to do their job. If you go to the next slide, this is the opposite of that. So I think we all know, and we've heard about the challenges of EHRs and how difficult it is for all members of the clinical team to do their jobs because of the EHRs. And I would argue that the only reason EHRs have scaled to the extent they have is because they were really required to for both regulatory and financial purposes. It was originally a billing system. But this kind of gives you an example of the opposite of making something the right thing to do. And next slide, please. So the last group of criteria I want to touch base on is this idea of implementation being feasible. And I specifically want to focus on the importance of overcoming barriers to systems integration. And again, I'm going to pick on EMRs and in particular Epic on this one. So I think so much of the innovations that we're all trying to do need basically data that come from Epic. And getting data out of Epic and into Epic is incredibly hard. So one recommendation, if you're evaluating care models, is there any way you can avoid the EHR completely? That would be the first thing, is can you circumvent it? If it's not possible to circumvent it, it's getting easier and easier these days to actually get data out of Epic. So there's application program interfaces that Epic is now starting to provide. There's a standard called the FIRED standard. All of those things can be used to extract data, but what's still really a problem is getting data back into the system. So if that's a requirement of something you're looking for, I would highly recommend really getting a very strong HIT expert to kind of look at how you would integrate. And again, this is just fine on a pilot. So if you're just trying to get into one epic or a few epics, you're fine. But if you're trying to get to scale, then this is something you need to look at really strongly. So with that, what I've been touching upon is primarily the criteria that's needed to get innovations to scale, but it's not just the innovations, they also have to be part of a sustainable business model. And I'm going to turn it over to Meredith, who's going to talk a little bit about the key elements of a business model needed for scale and sustainability.
Thank you, Loren, and I'm assuming everyone can hear me. That was really informative, and I think it does a really good job of laying the groundwork for why it's so important to have a very sustainable business model that will support, from an organizational perspective, the healthcare innovations that you just discussed there. Many of the examples you gave actually talked about the various shortcomings that exist when a full business model isn't thought out. So for example, when Loren just mentioned there about the challenge in integrating home-based care into the workflow, it's a great example of some of the challenges of not having a comprehensive business model necessarily thought out or executed in the process. So what we have here is actually an example of something called the business model generation. It's a really popular tool, started in the startup community, but really has expanded. And it basically takes away the reams and reams of paper undergirding a traditional business plan and puts on one page a very simple overview of what a business model could look like, really for any kind of organization, regardless of the sector. And obviously, in some cases, certain elements are more important than the others. And if we can go ahead to the next slide, please. I want to highlight a couple things there. And actually, before I talk about what's highlighted, I want to talk about what's not highlighted, which are in white. What you have here are several of the elements of an overall business model that I think many organizations do a great job distinguishing themselves around. So for example, the value proposition in the middle, that is effectively what is the differentiation of an organization relative to competitors, what is the main unique benefit that they're providing in their service. In many cases, especially new interventions, do a good job of articulating what that is. They're also good in the classic things of understanding what a revenue stream needs to be or a cost structure, and then the activities that support the value proposition to make those things happen. And I think that in many cases, a lot of ideas go to market with just some of those and maybe bare bones around some of the other elements, which are highlighted here in blue. Many of the things that we highlighted here in blue are effectively the shortcomings that are often overlooked by organizations when they're going ahead trying to scale their interventions. And most of these are actually related to go-to-market strategy, whether it is marketing to an end user as a patient or whether it is through a partner in a more classic B2B2C model, or is working through an institution like a healthcare organization. And so just to give an example here, for example, if we talk about channels, we've spent several years now working with an organization that has a very differentiated education product that is very good in understanding who their customer segments are, but where they really struggled is actually around getting enough people to participate in their educational offerings. So here they really struggle around channels and around key partners. And in many cases, these partners, as mentioned, could be institutions that they're partnering with. They could also be other organizations that are all part of the ecosystem. And this has been sort of a barrier in going to scale. And when we put our funding hats on, I think it's really important for foundations to recognize that they have a role in helping organizations go to scale, simply by helping to build an ecosystem, making the introductions, bringing together the right partners together so that everybody's business model is synergistic without being redundant. The other piece to mention here is around segmentation. I think in many cases, a lot of organizations sort of think there is a one-size-fits-all model, or they're in a if you build it, they will come perspective. And again, an detailed, nuanced understanding of your customers, both any intermediaries or end users, is really pivotal in understanding what kind of product you have. For example, if you are out selling a proposition, to direct care workers, and it needs to be very different from if you were selling a model to family caregivers or if you were selling it to clinical caregivers. And while of course all of these sound obvious in hindsight, in many times they're often overlooked. So again, when a foundation is supporting an organization on their path to scale, it's really important that they ask these critical questions to help organizations who may not have arrived at these answers already, and that they also participate in funding the design of business models. We work now with several foundations who are very forward-thinking, who have gone ahead and actually funded the development of this business model canvas and furthermore robust business planning and financial modeling underneath it that really helps organizations ensure that they can take their intervention to scale. I think with that, actually, we can transition over to Erich, if you can go ahead to the next slide, please, who is effectively going to continue to talk about the role foundations can take as they help organizations move to scale once they have established the criteria that Loren mentioned. Once they have built a sustainable business model, the next step is actually how foundations can match the types of investments over time to help the organizations to scale, and what are realistic expectations to help organizations as partners around what is a very complex and long-term process when we're talking about healthcare interventions. So with that, over to you, Erich.
Thanks, Meredith. Appreciate it. Next slide, please. As Meredith mentioned, organizations and interventions typically travel on a path to scale. And we want to touch on some of the considerations for funders to think about as you match your investments to organizations or interventions at different stages along this path. And on page 18 is a framework that was based on some work by Roger King, but I found some of the vocabulary has become fairly common in the nonprofit world over the next 10 years. So I won't spend a lot of time on these stages, but typically the path involves a pilot stage where intervention or product is tested at a smaller number of sites, often under very controlled circumstances. And here, size is not always a good indicator. Pilots need not be tiny. You know, Sutter's substantial advanced illness management program was developed with CMMI funding, but is still essentially a pilot. It has not yet moved beyond Sutter. Second stage, the flagship or replication stage. Now that efficacy has been proven during the pilot, the flagship stage is really about high quality delivery systems into multiple settings and sites and building the organizational infrastructure to support this. Thirdly, the broad adoption stage sees the product or intervention adopted widely, and the focus becomes more on distribution channels, selling into new markets and organizations. And finally, the new normal, where hopefully the intervention or product is fully accepted as best practice and a sustainable funding source has been located. The path is not always linear, and there are many attempts to skip some of these steps, but we would argue that those are the rare exceptions of success when doing so. Next slide, please. This chart represents the typical arc of revenue sources as an intervention product scale. So heavier grant funding at the pilot stage, peaking at the flagship stage, and then being eclipsed by earned income at the later stages. So what are some of the ways a foundation can help accelerate good programs through this path instead of having them drop out? Because that's really what we're looking to do in terms of scaling. During the pilot phase, funding for measurement and evaluation is particularly important at this stage to prove outcomes, show that path to sustainability. And foundations can also be important partners in this area for brokering partnerships. For instance, an emerging physician education program that is able to partner with a large health system for its pilot can just be that much more ahead of the game, as they can actually track the program's influence on health outcomes. Whereas if they didn't have this institutional sponsorship, they might not only be able to report on knowledge gain or self-reported satisfaction. And foundations can be, in a non-monetary way, can be important in brokering those partnerships. In general, smaller amounts of funding, outside funding, are sufficient to catalyze pilots, so it's a good place for smaller funders to participate. In the flagship or replication stage, here funding for operational and administrative support is particularly important. Infrastructure to manage multiple and larger implications are needed. There's tends to be a lot of staff turnover as different skill sets are needed between the phases, and supporting this onboarding of new staff can be particularly helpful. Data collection also moves from more of a what data to capture to how to capture the right data on an ongoing basis. And typically the stage does require larger funding dollars and represents the peak of outside funding, but there are still really meaningful ways to get involved with smaller dollar amounts. Mark mentioned earlier funding collaborative mechanisms, which I think is a great way to have impact at lower costs, and also non-monetary support, very helpful at this stage as well, connecting organizations to new board members, helping recruit staff, introducing to potential partners, and so forth. Broad adoption, earned revenue becomes a larger portion of these implementations, but outside funding still plays a critical role. Funding of things like playbooks, implementation blueprints, and TA, technical assistance to new sites, clearly presenting the business case, and policy and brand awareness also very important at this stage. Like the pilot stage, this can often be catalyzed with relatively modest amounts of outside capital, as we've seen here in California. California Healthcare Foundation was very successful in catalyzing inpatient palliative care in many of the hospital systems here. And then finally, last stage, grant funding takes a back seat, earned income and sustainable funding start to take over. These are just some of the forms of funding and non-monetary support that a foundation can leverage, but more broadly, be aware of what stage the organization or program you're supporting is in, and keep this in mind as you think about what to fund and what success looks like within that stage. I'll turn it back over to Loren to wrap up.
Super, thanks, Eric and Meredith. So just in summary, I mean, based on the work that we've done with organizations and foundations, I think you can see that it's not easy, but there's certainly a lot of experience we've all had and literature that's out there to help us sort of to kind of figure out the path. And so hopefully that this has helped you. And I'm going to stop here just to leave some time for some questions. Thank you.
Well, thanks one and all for those excellent presentations and showing us both the complexity and the opportunities here in this arena that more and more funders are looking at. So to remind everyone, if you have questions, please continue to type them into the question box, and I will be asking our panelists today about those. I will start by directing the question at one person, but then I will be happy to have anybody's answer to the things we're going to be talking about. So, Mark, let's start with you. Obviously, the Camden work has been well developed and also well regarded in the healthcare and complex care world. So could you talk a little bit more about the specific experience that led to the creation of this kind of mechanism? Is it primarily around trying to get others to be involved in this, or is it more specific than that?
And John, you're asking about the National Center specifically?
Yes.
Yeah. So I think the National Center sort of grew up having, based on experience where we were being called into lots of different communities to provide coaching and technical assistance. And we were also becoming aware of other programs and models that were serving different subpopulations as effectively or more effectively than what we had developed in Camden, and really needing a place for an exchange of information and best practices, and just some sort of center of all of these different efforts that were going on around the country. So it's not about replicating a single model. We understand that there are many different models that need to be tailored to the particular needs, subpopulation, and community in which they're being served. But we do think there are core principles, core competencies that sort of identify what's effective about complex care that's different than sort of traditional healthcare. And we think that those warrant having some collective efforts to both define them and teach them. So the work of the National Center, in addition to convening, is also focused on thinking about what those core competencies are, elevating examples of teaching and training in that space, as well as white papers and toolkits and other things that can help to spread the practice. Also doing similar things in the space of research and on the policy side. So it's a really ambitious agenda, and one that we recognize is going to take years to accomplish, but is designed to really facilitate the collaboration of lots of different organizations that are working in this space.
Well, thanks. I think the next one will be for Loren, Erich, or Meredith to tackle, which is a question about mission investment. We have heard for some period of time a lot of discussion around pay for performance, and sometimes that gets merged into things like social impact bonds and now mission investment, a variety of ways around using foundation resources which are not strictly grant related. Is this an area that you're working in, and do you have specific advice for members of the foundation community about the utility of that method?
Yeah, this is Loren. I can speak to that. It's actually something we've been researching recently, specifically around providing social supports. So there's, as you all know, there's a ton of research, and what our goal ultimately is to shift dollars from the healthcare system into the social services sector. And one of the best ways to do that is for pay for success type contracts. And a great way for foundations to do this is actually by paying for the transaction cost. So there's organizations that specialize in this, and they have access to a tremendous amount of investors. They also have the capacity to analyze the potential investments to make sure that it will have that positive impact. And so the role of the foundation is one where you're really just paying the transaction cost for one of these really great pay for success programs. And I think it's an excellent way for foundations to have an impact.
Right. Go ahead. I'm sorry.
Yeah, I was going to say, if anybody is specifically interested in that, I'm happy, if they want to reach out to me, I'm happy to point them to a few different organizations and some of the literature there as well.
Okay. Erich or Meredith, anything to add to that? Okay. So I think we are closing in on our time here. So at this point, I would like to ask each of our panelists to give us their words of wisdom as we move to the end of this topic today. And Mark, I'll ask you to start.
Sure. Thanks, John. I guess my words of wisdom are really that in a lot of communities, I think you need to start small, and it's really about bringing people together, people that maybe haven't worked together in the past, but creating some spaces and infrastructure where they can come together, realize what they have in common, and start to plan for ways in which they may collaborate. I may be biased because that's sort of the history of the Camden Coalition, but we see this in communities around the country where you get sort of unlikely bedfellows together and magic starts to happen. So I think merely the act of bringing people together with the right sort of doses of data and good facilitation can generate really powerful energy and activity in this space.
Thanks, Erich. Sorry, Mark. Loren, can I ask you for your comments?
Yes, thank you. So, Mark, I would second that. And in addition, foundation resources in this area are so precious. So, as we've said before, there's certain innovations that where they are right now is exactly where they need to be, and there's ways to support them. But if you are looking at trying to get innovations to scale, again, I would just know that it is a difficult and possible but difficult path, and just do your research up front so that you can invest your money in a way that can have the most impact.
Thanks. Erich? Let's see. Erich, are you with us? Meredith?
Yeah, I think I would, echo the points that I've heard around, really being wise and strategic in using the foundation dollars to support the overall growth of the industry. And I think one of the most important things to keep in mind for foundations is how to be a great partner, right, and not perpetuate donor-led philanthropy, but instead about building the ecosystem, starting with amazing local level organizations like Mark addressed, and helping them on their path to scale and working in partnership through creative ideas like the social impact bonds in order to advance growth and really begin to serve the most people in need for such a dire issue.
Well, thank you so much.
Sorry about that. I was on mute. I echo both my colleagues, and the only thing I would add is don't be hesitant to reach out to fellow funders, to the folks on the call. There's a wealth of resources out there, and as far as I know, everyone is happy to share towards the impact in this area.
And specifically in this regard, the joint project that Grantmakers in Aging and Grantmakers in Health have around trying to disseminate information and foster more involvement of the philanthropic community. So contact any of the staff members in either of those organizations. We'd be delighted to talk to you about that. So I want to thank Mark Humowiecki, Loren Pogir, Erich Bagen, and Meredith Lobel, and for all that they do to make life better for older adults and people of all ages, and for sharing their knowledge with us today. I also want to thank the Five Funder Collaborative, the Commonwealth Foundation, the John A. Hartford Foundation, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation for the support of this work and of today's webinar. We will be making this presentation available to anyone who wishes to view it later, including both the slides and the audio. Please watch for a rebroadcast link on our website. And finally, I want to thank all of you for participating in today's webinar. Have a great day.